Professor Abdullah, thank you. Sorry for my fancy outfit. I had actually cardiogenic shock this morning at 5 a.m. I wish I had been able to bring the pictures, so I'll share the pictures during next presentation. This is mostly of review and really basics of cardiogenic shock. So I'm going to go through 10 items, and the 10 items are named fact or fiction. And these are items that we have discussed previously in most recent presentations. So fact number 10, mortality of patients with cardiogenic shock has remained unacceptably high. We've discussed in multiple venues that the outcome of patients with any sort of cardiovascular disease, even pulmonary embolism that was recently discussed, any sort of cardiovascular disease, their outcome has improved, but unfortunately mortality of patients with cardiogenic shock has remained high and has not changed significantly over the past number of years. This is an older data that's shown the cardiogenic shock mortality is in the range of 50%. And as I've mentioned before, you may say, well, Dr. Heidar, this is old data. And you're correct. I'll show you old data to contrast it with the most recent data. Now, this is recent data published in just a few weeks ago in NAJM from the ECMO trial. Now, I'm not showing it to you for ECMO, but I'm showing it to you that if you look at both arms, whether it's ECMO or non-ECMO, the mortality is exactly the same. So take away the arm that were treated with ECMO, the mortality of patients with cardiogenic shock is 48–49%, which is essentially the same what it has been over the past number of years. Second fact or fiction, which is fact, is detailed knowledge about the stage and type of cardiogenic shock improves multidisciplinary communication and potentially leading to improved survival. Now, I had a patient this morning. He was a 55-year-old German tourist who was vacationing in Dubai and comes with extensive anteroseptal ST elevation. And in my communication until I got to the emergency room at 5:30 in the morning, these were all the explanation that I was given. Patient was shocky, was borderline shock, pre-shock, early shock, mild shock, and severe shock. These are the names which are unfortunately used, and these are the names that needs to be taken out of our vocabulary in order for us to be able to improve the outcome of patient with cardiogenic shock. Now, this particular patient that I'm saying was a stage A going to a stage B cardiogenic shock. He was not hypotensive, but he was hypoperfusing. This is data from SCAI, both their initial data from 2019 and then 2022, classifying stages of cardiogenic shock. The patient that I had earlier this morning was a stage A. He came with extensive anteroseptal MI. His blood pressure was 110/70. His heart rate was 102. But when we checked his lactate in the emergency room was 3.84, which is depending on the assay that you use, would qualify as hypoperfusion. Now, the investigator from cardiogenic shock working group in the US have further granularized the data of the cardiogenic shock, specifically with regard to a stage B. Stage B of SCAI count as being hypotensive, but in certain patients, especially heart failure related shock, you could be normotensive but hypoperfusing. So checking lactic acid level in these patients become very essential. Third factor, so number 8, in patient with cardiogenic shock, time equals mortality and time equals survival. And the reason is cardiogenic shock is a very complex, initially hemodynamic, which then becomes a cardiometabolic issues. And if we don't address it at the stage of hemodynamic and reach cardiometabolic, unfortunately, it becomes too late. Initial parameters for us to check is our hemodynamic, but by the time our lactate, our pH become acidotic, unfortunately, it becomes a cardiometabolic. The data that we need to monitor in these patients in addition to hemodynamics, are lactate and, of course, endocrine monitoring, including kidney function and liver function tests. These patients that I spoke earlier came with borderline lactate, but normal creatinine and normal liver function test, including ALT. But these can lead to multi-organ failure. This is data from both National Cardiogenic Shock Initiative and also Innova Group, that for every hour that passes in optimal management of cardiogenic shock patient, the mortality of patient with cardiogenic shock can go up twice, 3 times, 4 times. So we used to talk about door to balloon time and what is the golden hour to improve reperfusion. Really, in this patient is door to support time to decrease the mortality of patients that go up with every hour. But sometime it may be too late. This is a publication from AHA, which used all the patients and applied the SCI classification. And if a patient comes in a stage E, the mortality of that patient in the emergency room at the time of arrival is about 80%. So in the era of resource utilization, and I'll show you data on the expense of these patients, we need to be careful about application of available support system to what patients. If patient comes in class C, maybe that patient is eligible to receive every treatment modality. But if the patient is stage E with a mortality of 80%, resource utilization needs to be justified. Shock team, next item. Shock team and shock protocol are associated with improved survival. Data from Innova Group, National Cardiogenic Shock Initiative, both in Europe and in US have shown that having a shock team at institutions that take care of patients with cardiogenic shock improves survival. The reason, the ingredient of shock team usually consists of emergency room, and this is what our institution includes: emergency room team, interventional cardiology, critical care, that may be cardiology intensivist or critical care intensivist, anesthesiologist. This is the protocol from National Cardiogenic Shock Initiative that we use, and I know our colleagues in Ras Al Khaimah use, and also in Abu Dhabi. So variations of that available, but the main item is door to support time in those patients who qualify and when such support is available. And the main data that would use to help you escalate or de-escalate mechanical circulatory support are cardiac power output, which relates to left ventricular support, and PAPI or pulmonary artery pulsatility index, which relates to right ventricular support. This is looking at different centers where the Cardiogenic Shock Initiative and shock protocol and shock teams are available, and in time, its survival has improved. Obviously, this is not randomized data, so they should be interpreted with caution, but do improve survival. Numbers do not lie. Having a longitudinal data about patients can lead to therapy modification and potentially improve survival. What do I mean by that? If we're not checking anything on patients with cardiogenic shock, the one thing that we need to check is lactate. Lactate as a point of care in emergency room, in the cath lab, in ICU, and every 6 hours. Because having a lactate of more than 4, especially if associated with cardiac power output of less than 0.6, leads to less than 70%, so 30% survival. While if your lactate is less than 4 and your cardiac power output is more than 0.6, then your likelihood of survival of the patient is more than 95%. Inotropes have been around for a long time, probably before some of us were born. And the cardiogenic shock survival, as I've shown you, has not changed. So let's agree that inotropes do not improve survival. It doesn't mean we shouldn't use it. We can as a point of care on the initial contact, but that should not be the treatment modality in patients with cardiogenic shock. I showed you this slide already. cardiogenic shock mortality has remained around 50%. And this is another slide from National Cardiogenic Shock. With the number of inotrope going up, the mortality goes up. It doesn't mean inotrope hurt, but it may reflect patient severity. So inotrope is not a treatment, sustained treatment with cardiogenic shock. This is also from National Cardiogenic Shock. Inotropes and cardiac power output. If you're on 2 or more than inotrope and your CPO is less than 0.8, 0.6, then survival is 35%. Vice versa, if you're on 0 inotrope and your cardiac power output is 0.6, 0.8 or greater, your survival is 90%. How about mechanical circulatory support and survival? Well, it depends on what mechanical circulatory support. From IIBP shock trial, we know at least the way the trial was conducted, and it was a hodgepodge of a balloon pump before, during, after. Intra-aortic balloon pump did not improve survival. As a result, the classification changed from 2A to 3 for balloon pump. How about ECMO? Recently published in October. As I showed you, the ECMO, the way it was done, did not improve survival in patients with cardiogenic shock, and in fact, it was associated with higher risk of bleeding as well as increased vascular complication. How about Impella? Now, we have quite a bit of data about Impella improving outcome of cardiogenic shock. Most of these are registry data rather than national or multi-center randomized trial. But in NCSI, which is was done across US, and I trained at one of these centers, the survival now is in the range of 70 to 80%. So if it's done through the right path, right protocol, cardiogenic shock, then it has the potential to improve the survival significantly. RECOVER 4 trial is evaluating Impella pre-specified early with subgroup analysis of patients in patients who have cardiogenic shock, especially evaluating patients who come with class C, D, and E type of cardiogenic shock. Cardiogenic shock is expensive, so resource utilization and allocation is important. This is data presented just literally 2 weeks ago in Journal of Society of Cardiovascular Angiography and Intervention. This is data from national inpatient sample. Now again, this is a retrospective looking at of the data. The patients who had cardiogenic shock and they were treated with ECMO, balloon pump, and Impella, and you see the median cost of these patients. This is in dollars. You can calculate it in UAE dirhams, but they are anywhere from 130,000 to 190,000 dirham cost, dollar cost associated with care of these patients. So this needs to be done in a proper fashion at centers with access to both treatment modalities and expertise to take care of the potential complication of these patients. Fact or fiction? With leadership of Professor Shahab, this is a fact. We have started the Emirate Cardiogenic Shock Initiative and Emirate Cardiogenic Shock Working Group. Last week we had, 2 weeks ago, we had our first meeting, and hopefully with regular meeting supported by industry and hopefully leading to society from Emirate Cardiac Society guideline in the country, we would be able to uniform the treatment of cardiogenic shock provided here both locally and hopefully in the Gulf region. And fact number 1, I've already mentioned this, but I think it deserves mentioning that mortality of patients with cardiogenic shock has remained unacceptably high, and we need to do every effort to change that. Thank you very much.